Hello all, welcome to the new session with EMD, that is EMdairies with Ajith. I'm Dr. Ajith Venugopalan and I'm a faculty in emergency medicine. This session is about rapid sequence intubation. I'm sure that many are familiar with rapid sequence intubation. Let's try breaking it down. Let's come to a session that we have a case of a 68-year-old male brought to our department in an unresponsive state. The airway looks compromised. The patient's breathing is respiratory rate around 9 per minute with saturation 68%. How do you proceed? For any patient that comes to the emergency, the basic three components that you follow is triaging an initial impression, primary assessment where you are stabilizing the physiology, and secondary assessment where you're going to have a detailed evaluation. In this case, the challenges are two. There is hypoxia, there is hypoventilation, along with the airway is compromised. How do you proceed? You have to have a proper history and clinical evaluation and also cause evaluation, along with simultaneously managing the patient. The patient's airway has to be patent. You have to clear the airway and maintain the airway. You have to have a proper oxygenation and ventilation, and you have to make sure that there is a chest rise even if you are going with a bag and mask ventilation. And if all this are having compromise, consider definitive airway. Also, you can use adjuncts along with your clinical evaluation like ultrasound. That is then EFAS to Repocus, where you are going to evaluate for lung sliding line, whether there is an pneumothorax, whether there is a hemopneumothorax, or there is a hemothorax or a pleural effusion. So you are actually evaluating using the ultrasound to make sure that you have an extensive clinical evaluation along with your physical examinations. Coming to rapid sequence intubation per se, as you all know, airway takes priority. RSI can be broadly considered in any case where you're going to simultaneously administer rapidly acting sedative, that is the induction agent, along with a neuromuscular blocking agent, that's a paralytic agent. So any situation where you're going to incorporate a rapidly acting sedation along with a neuromuscular blocker to create an optimal situation for intubation and to enable a rapid control of airway. Such situations are called as rapid sequence intubation. There are different terminologies, but we'll stick on to RSI. And here you have to create an optimal intubating condition and enable rapid control of the airway. And why we do all this is to minimize the risk of aspiration. Because in emergency and most of the time in any situation where it demands an emergent intubation, we have no clue about how the patient's airway is, and also we have no clue how the patient's gastric content, the NPO status is. So in such situation, it is always better you go for RSI to make sure there is a risk of aspiration is minimized. Always the 7 steps has to be followed. These are the 7 key steps that you follow for RSI. The step 1 is preparation, 2 is pre-oxygenation, 3 is pre-treatment, 4 is paralysis with induction, 5 is protection with positioning, 6 is placement of the tube, and 7 is post-intubation management. These are the 7 steps that you follow for RSI. And there are different time span for each step. For preparation, it says that it can be done in 10 minutes, but I would say that if you have a proper system in place where you are practicing a proper emergency care, preparation phase can be reduced to minimum because you have already pre-prepared for most of these conditions. Pre-oxygenation can vary from 3 to 5 minutes. Pre-treatment is around 3 minutes. Paralytic and induction goes simultaneously. Protection with positioning, placement with both proof, and post-intubation management. We'll go to step 1, that is preparation. How do you prepare yourself for any such situation? Preparation can be broadly divided into basic preparation and airway specific preparation. Basic preparation starts with PPE, your mask, your gloves, your gown, your cap as required, and goggles as required. Then you can have all the basic monitors prepared. Basic support team also has to be there. You have to have the airway supports. You should have the suction apparatus and including the ventilator settings and the monitors. Make sure that you have the comprehensive system where in and out from the procedure has to be smooth. The airway specific preparations can be airway assessment, airway management plans, assembling the necessary equipments, assembling the necessary medications, and make sure that you even consider difficult airway management plan. And that is out of the scope of this topic. Maybe we'll cover it in some other session, but make sure that you have a difficult airway management plan also in place. Mnemonics that can be used for tracheal intubation preparation is STOP, MAID, STOP, MAID, where S is for suctioning, T for tools for intubation like laryngoscope, blades, handles, video laryngoscope, and other devices. O is for oxygen source for pre-oxygenation and ongoing ventilation. P is positioning. M for monitors, that includes ECG, pulse oximetry, BP apparatuses, continuous BP monitoring, ETCO2, esophageal detectors, and so on. A is for assistance, ambu bag with face mask, airway devices, airway assessment, and all those. I is intravenous access. You should have preferably two large bore cannula, because you are going for a difficult airway. You can have a difficult airway, and you don't have to, at that time, you don't have to struggle anything with the line that you have. You should have a proper flushed line. And D is for drugs, that can include induction agents, neuromuscular blocking agent, and also other desired fluids and drugs and all those things. We'll just have a brief about laryngoscope. You should have a laryngoscope which is normally has a handle. It has a hook. Then you have a blade that has, and the blade is also having a beak, that is our tip that is there. Along with that, it has a light source. Light source, you have a battery, you have a focus lamp, and you have a fiber optic bundle and the light outlet. Commonly used are two types of blades: the Macintosh, that is a curved blade, and the Miller's, that is straight blade. The basic difference between these two blades is the curvature. The Macintosh blades are mostly used for adult, whereas Miller's blades are mostly used for pediatric and neonates. Macintosh blades have 0 to 4 size, where 0 is the smallest and 4 is the largest. Whereas Macintosh or Miller's also have similar, but there can also have 0 also, mainly for preterm babies. Whenever you use both the scope, either of the scope, what you are actually looking at is an epiglottis. You have the vocal cords, you have the cartilage, and you have the trachea inside. So this is the basic view that you are going to get whenever you use any of these scopes. Whereas if it is a Macintosh blade that you use, that's a curved, the difference is you're going to get the tongue and epiglottis. You are going to, the scope, the blade goes in between the tongue and the epiglottis, that's the vallecula, and you are going to lift the tongue along with the epiglottis, and the tongue, basically the scope goes in between the tongue and the epiglottis, and you're going to pull it up. And what you're going to visualize is the epiglottis, and as I said earlier, you're going to visualize the vocal cords and also the tracheal cartilages and the trachea inside. Whereas if it is a straight blade, that is a Miller's blade, you are actually going to take the epiglottis along with it. Whereas in curved blade, the epiglottis and the scope goes between the epiglottis and the tongue. That's basically into the vallecula. But whereas in a straight blade, that's a Miller's blade, you're going to take the epiglottis along with it. So basically epiglottis is taken along with it, and you're going to see the rest of the structures, that is vocal cord and the cartilage. And you're going to posterior to that, you can see it will be the esophagus. So understand that there is esophagus behind it, and what we are going to tube is into the trachea. And you should have the awareness about the endotracheal tube. Endotracheal tube has an adapter. It's a PVC tubing. It has an adapter. It has a radio marker basically along with it, which helps us to identify this in X-rays. You can have a vocal cord guide, which you can understand that once it is crossed, the black line should cross the vocal cord. You have the cuff, which makes sure that it prevents aspiration. And you have the Murphy's eye, that is on the lateral aspect. You have the bevel, that's opening. And you can have the pilot balloon, where you use it for inflation. Once you have put the tube in position, you inflate it and make sure that the cuff pressure is also checked. For pediatric tubes, these are the commonly used measurements, and for cuffed pediatric tube, it's age by 4 plus 3.5 is the internal diameter calculation, and we have the various size that you commonly use for that. We can go in a depth about the ET tube size and depth. The commonly used ET tube size for average adult male, it is 8, female it is 7. For pediatric, if it is uncuffed, the calculation is age in years by 4 plus 4 for a uncuffed tube, where if it is a cuffed pediatric, which you commonly use more than 2 years, it's age in years by 4 plus 3.5. When it comes to the depth of the tube, it is usually measured from the central incisors. So when tube is in, from this area you're going to measure it, and the measurement, there are markings in the ET tube. If you have seen the ET tube, earlier ET tube, you can see you have seen the markings in the ET tube. And for the depth, you can use the Chulan's formula. It's not commonly used. It's 0.1 into height in centimeters plus 4. For adult, typically it is 23 centimeters, and female it is 21 centimeters. But whatever it is, make sure that you have examining the tube is in position, either with a and done a 5-point auscultation, and make sure that tube is in position. For pediatric, for age more than 2 years, depth can be calculated as age in years by 2 plus 2, or you can also use 3 into depth internal diameter for also measuring. So these are the basic methods in which you calculate it. But whatever said and done for ET tube depth, make sure that you confirmed with the 5-point auscultation, and make sure that the tube is above the carina. Now coming to the second step, that is pre-oxygenation. Pre-oxygenation means nitrogen washout or denitrogenation. Basically what we are trying to do is, we are trying to give oxygen and to increase the concentration of oxygen in the alveoli, and in turn it will increase in oxygen saturation inside the blood vessel. And majorly why we are doing it is to provide proper oxygenation and to prevent hypoxia during our intubation attempt, because while we are intubating there is a period of apnea. So we are trying to tide over the apneic period with a proper oxygenation that is prior to intubation. And one thing I want to tell very clearly at this point is, normally what we think is that it should be achieved, pre-oxygenation can be achieved by bag and mask ventilation. It is not. Bag and mask ventilation is one of the methods of pre-oxygenation. There are other methods also. If the patient is cooperative, SA8 vital capacity breaths is enough to provide pre-oxygenation. Otherwise, even giving a high flow oxygen through a non-rebreather mask is good enough to provide pre-oxygenation. Bag and mask ventilation can also be used, and I'll tell what are the indications of when can we use bag and mask ventilation in the coming slide. So understand clearly, pre-oxygenation is to provide oxygenation and to prevent apnea during intubation attempt, and it can be achieved by high flow oxygen devices, and even in cooperative patients we can give 8 vital breaths is enough. And even we can use CPAP, positive pressure ventilation, positive airway pressure, that is CPAP, can also be used in patients who can tolerate that. And also the bag and mask ventilation. Positions, if the patient does not have any spinal discomfort or spinal injuries, you are not suspecting anything like that, and the patient is not immobilized, a head up 20-degree position is good enough. For immobilized patients, or if the patient is having a spinal injury, 30-degree reverse central lumbar position is recommended. Pre-oxygenation, again, you can use adjuncts, that is nasal or oral pharyngeal airways, and you can either use the airway positioning, that is chin lift or jaw thrust, depending on the situation, to maintain the patency of the airway. During the apneic period, make sure, as I told earlier, there is a period of apnea that can happen after pre-oxygenation when you are going to intubate. During the apneic period, even a nasal cannula oxygenation with a flow rate of 5 liters per minute is also recommended, and there are studies which have proven it actually extends the period of oxygen. Apneic period can also be extended by using the nasal cannula with a 5 liter during the apneic period. If the patient saturation is less than 93% despite high flow oxygen, and the patient is possible to provide a positive pressure ventilation with a CPAP if the patient can tolerate it. So as I told earlier, you can it is not always bag and mask ventilation. That's key that I want to convey in this slide. You can use bag and mask ventilation in certain criteria, which will come in the next slide, but you can also consider a proper vital capacity breaths if the patient is cooperative. You can make sure that the patient is given oxygen with a non-rebreather mask if the patient is tolerating that. You can even consider positive pressure ventilation if the patient is able to tolerate it. So before the important bag and mask ventilation, there are other steps possible, because bag and mask ventilation, the biggest risk is this: any bag and mask ventilation is going to overinflate the lung and also distension of the abdomen, and this can have a higher risk of patient going to aspiration. So make sure the bag and mask ventilation is reserved for these conditions, where the patient is having a hypoxia, that is less than 91% saturation, where the patient is having a slow rate, that is the patient is having hypoventilation, or even if the breaths are shallow breaths. And in such cases, make sure that you give slow rate. You don't have to overinflate the lung. So make sure that you give a low tidal volume, that is 8 ml per kg. That even if it is ambu, don't give all the capacities in the bag. That is not needed. It's basically a low volume ventilation that you give, and do not use excess force. Deliver breath over 1 to 2 seconds. So that is the timing that you have to make sure. Don't push it just to make sure that you acquire the adequate saturation. Don't do it, because you are going to not only spoil the physiology, but you are going to produce an over distension of the abdomen, which can result in aspiration, which is more riskier. So understand, you have to balance both in such cases where you're going to provide a manual ventilation. So once you have properly ventilated, in an adult male who's physically fit, around 6 minutes, the time of if you have given a proper pre-oxygenation, the patient's apneic period, you can expect that you can go for up to around 6 minutes, and from their phase, slowly it can come down. But if it is a moderately ill patient, the apneic time can reduce up to 4 minutes, whereas if it is a pediatric, the whole time reduce up to 2 minutes, whereas if it is an obese patient with multi-comorbidities, the whole thing can reduce up to around 1 to 2 minutes. And it slowly starts dipping, but the problem is, once, as you all know, the oxygen diffusion curve, once it starts dipping, it dips very fast. So you don't need to play around too much and spoil it. And so make sure that you have apnea time is properly provided with pre-oxygenation. And even if while you are doing with the procedure, you found out if there is some confusions happening, and you see that saturation is dropping down, abort the procedure, go back to pre-oxygenation, and then attempt again, so that you have an attempt and don't have a failure, and you don't have to have more complications. Once come to pre-treatment by pre-medications, it is basically administration of certain drugs before the induction phase, and it is mainly to mitigate the side effects you consider it can arise when you go for the induction and also the procedure. So these are drugs which helps us to mitigate those adverse effects, and it varies with clinical conditions. Certain cases we don't do a pre-treatment, certain cases you do a pre-treatment. And certain clinical condition, the drug used is also can vary. Commonly used are lidocaine, atropine, and defasculating agents. When it comes to lidocaine, the biggest advantage with lidocaine is basically it cuts off the hypertensive and tachycardic response that can happen during intubation. Mostly it is useful for any case where you are challenging with raised intracranial pressure, like any traumas or any bleeds, where you are suspecting a raised intracranial pressure, or you are expecting that the ICP is raised and you want to mitigate it completely. And in such cases, you can use lidocaine as a drug of choice. Its onset of action is within 1 minute. The dose is 1 to 1.5 mg per kg, and maximum dose is around 3 to 4 mg per kg. The second commonly used is atropine. It's mostly used in pediatric age group where you don't want to have a reflex bradycardia, because you know atropine is going to increase the heart rate. So to prevent a reflex bradycardia while intubating, that atropine can be used. But the concern, and it can also dries the secretion. So there are two advantages with atropine. But the concern is it can produce tachycardia. Action is within 30 seconds and peak action is within 1 to 2 minutes. Dose is 0.01 mg per kg, but a minimum dose of 0.1 has to be used. The dose is 0.01 mg per kg with a minimum dose of 0.1 mg. Defasculating agent, this is an interesting area where certain times defasculating agents, when you are administering drugs like a depolarizing agent as a paralytic like succinylcholine, it can produce certain side effects like fasciculations. If you have evaluated the patient and you feel that this is a risk, an added risk to the patient, you can use defasculating agent, which are non-depolarizing agents. 1/10 of the dose of a non-depolarizing agent like a vecuronium can be used as a pre-med, which actually reduces the adverse effect of a non-depolarizing agent like succinylcholine. So understand, when you are planning to intubate and when you are planning to use a non-depolarizing agent as a muscle relaxant like succinylcholine, giving a defasculating agent like a depolarizing, I'll just bring back the sentence again. When you are using a depolarizing agent like succinylcholine, these drugs can produce fasciculation and certain other adverse effects. To mitigate that, a non-depolarizing agent like vecuronium can be used as a pre-medication, and the dose is 1/10 of the actual dose of the patient. 1/10 of the actual dose of the patient. These are called as defasculating agents. It actually prevents the adverse effects of a depolarizing agent like succinylcholine. So the drug is a depolarizing agent like succinylcholine. The defasculating agent is a non-depolarizing agent like vecuronium. Hope the concept is clear. Now coming to the fourth step, that is paralysis with induction. The dose of each agent has to be pre-calculated, and to produce the desired effect, there is no titration because time is the crucial thing. So there is no titration. You calculate the dose, you give the dose, and the whole thing happens within 45 to 60 seconds. And main thing that you have to have is there should be a deep state of unconsciousness and analgesia, and with minimum side effects. There is no ideal induction agent. Induction agent choice also varies from case to case. Mostly we use one drug, but at certain situations combination of drugs can also be used. These are some of the commonly used induction agents. Etomidate, it's an imidazole derivative which has excellent sedation with little hypotension. The biggest advantage is the hemodynamic stability you get with etomidate, but the issue is it has to be cautious with cortisol suppression situation and like in sepsis, because it can have that it acts on the adrenal axis, the cortisol production axis, so it can have that cortical suppression and that can happen. So you have to be careful in such cases. Its dose is 0.3 mg per kg. And the patient, if it is hypotensive, a reduced dose is normally recommended. For ketamine, there's another beautiful drug is ketamine, but the issue is ketamine can produce dissociative anesthesia, and it can increase your hemodynamics parameters, like it can increase the BP, it can increase the ICP, but this increasing the ICP has been controversial, and lots of earlier studies were contraindicating ketamine for use in patients with raised ICP or possible raised ICP, but nowadays studies are saying that ketamine can be used in such conditions also. And it can have another biggest advantage is for bronchospasm. It actually acts as a bronchodilator, so it has a good role in lung related intubation cases, and the dose is 1 to 2 mg per kg. And certain times ketamines are combined with midazolam to titrate that post-amniotic effect that can have the dissociative anesthetic effect that can have with ketamine. Midazolam is another. Can be used as a single drug. It's benzodiazepine, but it has a dose-related myocardial depression and hypotension can have, and you commonly use the dose as 0.1 mg per kg is the dose. 0.2 to 0.3 mg per kg is the dose that you use for midazolam. Then the next drug is Propofol. Propofol is again it's a bronchodilator, but the problem again is dose-related hypotension can occur. It's 1.5 to 3 mg per kg is the dose. Thiopentane sodium is again an ultra short-acting barbiturate. It has a serboprotective and an anticonvulsant property, so that's the advantage that thiopentane sodium has. But the disadvantage again is airway issue, and also it can have, if the patient is having porphyrias, it can have concerns with it. Its dose is 3 to 5 mg per kg. Then very rarely used drug is methotrexate. That's again a barbiturate. Along with induction agents, the other thing that we simultaneously give is the paralytic agent or the neuromuscular blockers. Neuromuscular blockers can be broadly divided into non-depolarizing agents and depolarizing agents. Non-depolarizing agents are competitive blockers like rocuronium or vicuronium, whereas depolarizing agents are non-competitive blockers like succinylcholine. This complete concept of neuromuscular blocker is a complete topic for itself, so I am not going in detail about it as of now. Understand that there are two groups, that is non-depolarizing group and the depolarization group. And depolarization groups is going to produce fasciculations, and you're going to actually observe till the toe where the fasciculation is completed and all those things. Whereas non-depolarizing agent is a competitive blocker. Now coming to the dosage and the onset of action, succinylcholine is commonly preferred earlier. That's 1 to 1.5 mg per kg is the dose, 30 seconds is the onset of action, and duration of action can be around 4 to 5 minutes. Vicuronium is, as I told earlier, vicuronium comes in the category of a non-depolarizing agent. The dose is around 0.1 mg per kg. The onset of action is 2 to 3 minutes. So that's a hurdle that we have with vicuronium when compared to succinylcholine. The onset of action is a bit delayed. Duration of action is around 30 to 40 minutes. Rocuronium, the dose is 0.6 to 1.2 mg per kg. The onset of action is 45 seconds to 2 minutes. So that's an advantage that we have with rocuronium over vicuronium, is the onset of action is lesser, and the duration of action is 30 to 90 minutes. The concern that we have is, at this case, if once you gave a paralytic agent and you go into a situation that you can't intubate, then the challenge comes that you have to ventilate the patient somehow. And succinylcholine, the advantage is its complete duration of action is just 4 to 5 minutes. So when you just have to ventilate for 4 to 5 minutes, and the drug's effect goes off. But with VEC or ROC, the action goes up around 1 hour. So you have to ventilate for 1 hour even if you are not able to intubate that case. So that is the concern or the challenge that you have with non-depolarizing agent over depolarizing agent. So once you have given the paralytic agent, now the next step is protection and positioning. Now you may have to flatten. If you have put the patient in head up position, you have to flatten where you have the ideal position. And normally when you are intubating, normally it is said that the head should be at a level of the umbilicus, so that you have a comfortable intubation. Make sure that you don't strain your back. Make sure that your positioning is comfortable, because your in and out should be very smooth. There are recommendations to use Selix maneuver, that is a cricoid pressure, because you have already sedated and paralyzed the patient. So to prevent even a slighter risk of aspiration, there is cricoid pressure can be given. You palpate the cricoid and you press it back. So that's a method that you choose, and it actually said to reduce the risk of aspiration. Again, here also there is no need for, after all this also, no need of giving a bag and mask ventilation, unless otherwise the saturation goes below 90%. So to maintain saturation more than 90%, you can go for bag and mask ventilation. But if pre-oxygenation is properly done, these goes within that, and the saturation will be maintained. Again, there's no need for doing a bag and mask ventilation, because here now the risk of aspiration is very high if you do a bag and mask ventilation, because you are already sedated the patient and you have already paralyzed the patient. So risk of aspiration is going to be high. So make sure that bag and mask ventilation is only done in this situation if the saturation goes below 90%. Once we have given the induction agent and the paralytic agent, the next step follows is placement with proof. The starting of placement with proof is to make sure that the drugs have acted. For that, we are going to check the masseter muscle for its flaccidity. Once that is checked and you're sure that the drugs have been affected, you're going to take the scope on your left hand, and you're going to enter the oral cavity through the right side, and you're going to take tongue along with that, and you're going to sweep it through the tongue till the point where you're going to see the epiglottis, and you're going to go between the tongue and the epiglottis into the vallecula, and you're going to lift it up. Make sure that you are going to lift it up and not move your wrist and injure the teeth. There is a high possibility of that. So make sure you're going to lift it up. Once you're going to lift it up, you're having an anatomical visualization of the epiglottis, of the vocal cord, of the cartilages, and posterior to that you can see the esophagus. So this is the anatomical orientation that you're going to get. And once that is there, fix your scope. Make sure that you don't move the scope. Fix your eye into this and get some assistant to give this ET tube that we have actually earlier we have decided the size and what tube it is and all those things has been decided, and someone is going to keep that tube into your hand, and you're going to now enter into the oral cavity. When you're going to enter into the oral cavity, you're going to enter the ET tube through the right side corner of the mouth. One thing that you have to be careful is, imagine this is the trachea. Once you're going to enter, make sure that it doesn't block your vision. So it is very common that you're going to enter the ET tube and the vision is blocked. That should not happen. Your vision should be fixed. As I told earlier, your eye should be fixed, your scope should be fixed. You're going to enter it through the side. You're going to enter through the side, and you already have the visualization of the vocal cord. So you're going to enter it through the side and you're going to slide it into the trachea so that your vision is not blocked. And once it is entered, you can see the black mark that is going to cross the vocal cord. Then you're going to hold the ET tube and at the angle of the mouth with that same hand. It should not move. Whatever done, whatever said, until the tube is fixed, this hand holding should not go. And you're going to take the scope out, you're going to keep it, and you're going to ask your assistant to do a 5-point auscultation at that point and connect to waveform capnography. The most important thing right now is to make sure that the tube has entered into the trachea, and as of now we have done it visually, we can see it going into it. Now we need to confirm and we have to make sure that it has gone into the trachea. For that we can do two methods. One is EtCO2 monitoring, the other is 5-point auscultation. EtCO2 monitoring, that is either calorimetry or quantitative, can be utilized where waveform capnography is the gold standard. And then you connect that to see the waves, whether it is coming in or not. If the waves are proper, you are expected that it is into the trachea. And along with that, you do the 5-point auscultation. 5-point auscultation means you're going to auscultate 5 points. The first and foremost point that you're going to auscultate is the epigastrium, because the most commonest mistake or most commonest misplacement of the ET tube is going into the esophagus. So once you put the tube in, you're holding the tube, the assistant is keeping the ampu back connected. With the first ampu, you're going to check for whether there is a gurgling sound that is heard in the epigastrium. If there is a gurgling sound that you hear, it should be just with one ampu. Don't keep on ampuing. If you hear the gurgling sound in the epigastrium, you're going to pull the tube out, because you can understand that the tube is into the esophagus. The second place, if there is no gurgling sound that you heard, the second place that you are going to auscultate is in the left infraaxillary, because if the ET tube is in the trachea, we have confirmed by the first auscultation that it's not in the esophagus, it's in the trachea. Now the second most misplacement that can happen is it can go into the right bronchus, because that is the most straight bronchus. So this can go into the right bronchus. So once it goes into the right bronchus, you won't get a sound in the left side. So that's why you're going to check for auscultation on the left infraaxillary region, whether you can hear the sound. So if you can hear the sound, that means that the tube is in position. And then that you check the right infraaxillary, that's a third place, right infraaxillary. What you're going to compare between left and right is whether the sounds are equal, because you want the tube to be just above the carina, so that there is an equal ventilation that is happening to both sides. Then you're going to auscultate the left infraclavicular and the right infraclavicular. So these are the 5 points in the order: epigastrium, left infraaxillary, right infraaxillary, left infraclavicular, right infraclavicular. So these are the points, that the 5 points that you're going to auscultate, and you're going to confirm the position of ET tube placement. Once that is done, someone needs to be fixing the tube, and that is also another step which I'll come into the coming slide. The concerns that can happen is if there is an unrecognized ET tube misplacement. As I told, misplacement can to be esophagus or it can be to the right bronchus. The concerns that can happen is hypoxia, inadequate ventilation, pneumothorax because of barotrauma, excessive ventilation, that barotrauma, and because there is no proper ventilation to one side, there can have significant atelectasis. The other thing that you have to understand is, if at all you did not recognize that it was misplacement, and even though it went into the right bronchus, you're not getting a air entry into the left side, there are possibilities that you can misinterpret that as a tension pneumothorax for that matter. And if the patient is in an unstable situation or the CPR ongoing, it can just confuse the whole situation. So make sure that a misplacement doesn't happen. Make sure that you follow the steps of 5-point auscultation and DTCO2, and make sure that your tube is in position. Unless the tube is fixed, you're not left this hold. That's the most important thing. And now coming to the next and the last crucial step is post-intubation management, where it starts with tube fixing. Because you have confirmed the position, the ambu bag with the ambu inflation, that you have confirmed the position. Someone has inflated the pilot balloon and the cuff is in position. Cuffs help us mainly for preventing aspiration. So the cuff is also in position. And now you have confirmed with all the 5-point auscultation. Now you have to fix it. Most important and most crucial is that you're going to fix the ET tube, or you're going to anchor the ET tube at one go. You're not going to put the oral airway and then together the fixing it. That is not the step that you have to follow. You have to keep the ET tube. You're going to fix or anchor the ET tube with either it can be a tape, so you can just go around it and you can fix it, so that this ET tube is anchored. So even if you want to remove the oral airway or something like that, it doesn't have a confusion. The ET tube is always fixed. Then you can put the oral airway if needed. Then you can use one more fixing, and that can go through the oral airway. Along with that, there are other methods of tying, where you can tie it and fix it. There is tube holders. Tube holders can also be used. Tube holders are gadgets which can be used for fixing the tube. But whatever done and set, one most important thing is, once these are done, you have to make sure that oral hygiene is given importance, because patient's oral hygiene is important. As a result, it can, if there is a contamination, if there is something happening, it can go in for micro aspiration, and that can lead to even BAP or ventilator associated events. So these have to be taken into consideration. Then after that, make sure that you take a proper vital checkup. You again check your vitals. Make sure that BP is checked, because hypotension is common, mainly because of the fact that when you are giving a posterior airway ventilation, there is an increase in intrathoracic pressure, there is a decrease in venous return that is going to happen, and there is a decrease in cardiac output that is going to happen. So this can result in hypotension. Certain drugs that you give for induction can produce hypotension. There are a possibility that can produce the procedure can produce a raised ICP, that can have a complication. So there are different mechanisms in which hypotension can occur. So make sure that it is not there. And you check the vitals and everything, and you connect into a ventilator. And ventilator setting has to be done. Ventilator is a totally different topic altogether, so I'm not going in detail about it. Mechanical ventilation has to be initiated. Make sure that you have a proper tidal volume and proper pre-plug and everything is maintained, depending on the case. If the patient is going for a long-term management, consider sedation and paralysis. Along with this, you do a post-procedure chest X-ray, again to visualize how the lung fields are, again the tube position, everything can be rechecked. And along with that, you should make sure that you put a Riles tube and a Foley's catheterization. This also has to happen, and that also has to come in place. You stabilize the patient, make sure you have done the intubation. You have our case to begin with was the airway was compromised with hypoxia with hyperventilation. Now you have intubated the patient, you have made sure that the patency is maintained, you make sure that saturation is maintained above 94. You have to have a proper ventilator settings adequate for the patient. Ventilator setting is also out of the scope of this session, can be considered as another session. And so ventilator settings are also properly done to make sure that the patient is maintaining a proper tidal volume as required for the condition. Circulation, again, rechecked, vitals are rechecked, and made sure that depending on the situation, the patient hemodynamic has to be maintained. ECG has to be taken. Make sure, because already patient is intubated, so GCS is going to be E1B TM1 at that point. Make sure pupils are rechecked and everything. If not, the GRB is not done. If not done before, you have to recheck, but always make sure the GRB is done earlier. And you do the exposure and make sure that tubes and everything is placed, and do a proper secondary assessment, and if required, further imaging can be done. This is the whole nutshell about rapid sequence intubation. So putting it all together, RSI is a mainstay management in emergency airway management. It's one of the mainstay. Principle is basically simultaneous administration of a rapidly acting sedative and a neuromuscular blocking agent. And that's the basic principle that you go with any patient with a RSI. RSI has risk of aspiration, so it's our responsibility to make sure the risk is reduced. The 7 P's that you can always think about is preparation, pre-oxygenation, pre-treatment, paralysis with induction, protection with positioning, placement with proof, and post-intubation management. So the 7 P's is also crucial. And with this, I conclude. If there is any questions, you can put down, or you can mail me. This is my email address, this is my phone WhatsApp number. You can reach me. I would request you to subscribe my channel, the EMD, that is EMdairies with Ajith. If there is any sessions that you want me to take, also you can put down as a comment or email or WhatsApp. Anything is accepted. And I hope this session of rapid sequence intubation was useful for you all. Thank you, and see you next time. Take care.